Well, thank you for joining us today. And today's topic is looking at the opioid crisis through a generational lens. And some of our objectives for today are going to be the history of opioids, which is very interesting. If I could tell you the whole story, but we don't have time for that. And the start of the opioid crisis, which I was actually in practice when that started, and it really caused a lot of issues. What draws various age groups to opioids, national response to the opioid epidemic, common opioids used for younger and older populations. I think in order to understand why people use opioids or how they get started, we need to really look at what type of pain there is and how these opioids would have been wanted for people who needed them. The problem is we were lied to. The benefits and risks of opioids, the new eyes on pain management, the CDC had to get involved because, pharmaceuticals were, overprescribing. Typical age-related changes in older adults that would impact why older adults should be very, very careful taking opioids. And the demographics of pain in the older adult. And I think that's something we need to be conscious of, because how we experience pain as older adults and how younger people do are two different things. And then the risk factors. Just to take a moment, my name is Chris Petrick, and I'm the Director of Education here at Elderwerks, and I am a registered nurse. I've been in healthcare over 40 plus years, and I'm glad that you're all joining us today to talk about this. As I mentioned, I was a practicing labor and delivery nurse when actually the opioid crisis hit, and I'll explain a little bit about what happened with that. And hopefully that'll clarify some of the things that you may have heard or may not have heard. So let's talk about in the beginning, where did opioids come from? The opioid poppy was populated in Lower Mesopotamia, and the Sumerians refer to it as Hul Gil, or the joy plant. The Sumerians would soon pass along the plant and its euphoric effects. And in 1300 BC, Egyptians began cultivating trade routes across the Mediterranean into Greek and Europe. They found that it was very profitable, so they kept doing it. Hippocrates, the father of medicine, dismisses the magical attributes of opium, but acknowledges its useful as a narcotic and styptic in treating internal diseases, diseases of women, and epidemics. In 330 BC, Alexander the Great introduces opium to the people of Persia and India. Then we go to the 1300s. Opium disappears for about 200 years from the European historical record. Opium had become a taboo subject for those in circles of learning during the Holy Inquisition. In the eyes of the Inquisition, anything from the East was linked to the devil. So now we move on to kind of the other part of this early history. And after a 200-year hiatus from opium, it's reintroduced into European medical literature for recreational use in Persia and India, and we see more world trade. And then in 1843, what happens is they discover that morphine can be administered via a syringe. Heroin addiction then begins to rise to the alarming rates. Finally, the U.S. Congress gets involved and they ban opium. And in the wake of the first federal ban on opium, it becomes a thriving black market. In 1930, the majority of illegal heroin smuggled in the U.S. comes from China, Mexico, and Afghanistan also become suppliers. In 2009, the World Health Organization, or WHO, says 80% of the world's population does not have adequate pain relief. So that is when the pain movement begins. And again, this is kind of where, as a practicing nurse, I was involved kind of watching all of this happen. However, it's in a retrospective concept that I now see how the pharmaceutical companies were using healthcare providers to push their medication. So the pain movement begins, which is important. Don't get me wrong. We need to make sure that people's pain is taken care of. According to the World Health Organization, around 80% of the world's population does not have access to pain relief, and that is a sad state. The International Organization of Human Rights Watch blames a failure of leadership, inadequate training of healthcare workers, and overzealous drug control efforts. But pain patients were finally getting some good care. Organized pain treatment establishments popped up everywhere, including at veterans hospitals, universities, and even rural areas. So people were catching on that, okay, so, patients in general were not getting much attention on getting quick pain relief. Then we saw professional organizations, self-help groups, publications, and research did blossom. Money was good. Growth of the industry, the pharmaceutical industry, was exponential. The launching of the industry was quite vibrant, and the exuberance was fueled with the fifth vital sign, the new opioid formulations and the epidural corticosteroid injection. So that's when the opium formulations were figured, invented, created, researched, and also when we look at, for back pain, the epidural injection. Pain patients were finally getting some good care, and we know that. However, this is when Big Pharma gets involved. Undertreated pain and the movement towards pain relief opened the door for companies like Purdue, which is the big component of this whole issue, to aggressively market a narcotic drug that was never, ever taken by a pharmaceutical company. However, you do need to know that, sorry about that. Purdue had been accused of being a key player in America's opioid crisis. Now, I don't know if it's accessible anymore, but I believe it was on Netflix, and it talks about Purdue Pharmaceutical. The undertreated pain in the fourfold of the opioid use and misuse, and they really used that. In 2001, Purdue Pharmaceuticals was selling more than 1 million worth of Oxycontin in 1 year. Providers were told that Oxycontin was not addictive, and it continued to create and increase the dosage. So what they were actually doing is Purdue Pharmaceutical were sending out their sales reps, and the sales reps were getting compensated, and they were getting big budgets to kind of, pursue the doctors in giving Oxycontin to their patients. And many of the doctors were doing it based on the fact that they thought that it would really work from what Big Pharma was telling them and selling them. And then they started getting cash prizes. They started getting vacations. They started getting excursions, the doctors did, if they increased the amount that they were giving to their patients and, to different patients. What they found was that because of the long-term use, that it was getting harder for them to treat these people and get rid of their pain. So they were upping the dosages of them. They continue to create increase the dosage of these opioids. So what happened was people became addicted, although they told people, Big Pharma, Purdue in particular, was told that the opioids were not addictive, and they knew the whole time that they were. So that's when we see a rise in opioid overdose deaths in America. Nearly 500,000 people died from an overdose from 1999 to 2019. And you can see in the 90s what it looked like, 2010, because there were starting to get restrictions on how much a physician could dispense at one time. People were addicted already, and so they went on to use heroin, because heroin has the same effect as opioids. Obviously, you don't need a doctor's prescription for it. You can get it on the street, and it causes the same and even more severe side effects besides being high all the time. In 2013, it really marked the rise of the synthetic opioids, which is fentanyl, and now we see that there's a rise in deaths from that. So if we look at the national statistics, nearly 841,000 people have died since 1999 from drug overdose deaths that occurred in the US. Opioids were involved in 49,000 plus overdose in 2019. And then from 2018 to 2019 was the largest increase in death rate involving synthetic opioids in the West. So now we're talking the man-made stuff. Fentanyl, we're seeing it come in from China, from Venezuela, from Mexico. And I have to tell you that no state has experienced a significant decrease of opioid deaths. And in fact, they've increased from that. So opioid addiction is not only a crisis for teenagers, young adults, but older adults as well. And for many, it does begin with prescriptions that are given for an injury, a surgery, or chronic pain. Not every opioid addict lives on the streets or in shelters. They are from many walks of life: college-educated mothers, fathers, grandmothers, grandfathers, and college graduates. And like I said, it's a sad story that began in the 1990s by Big Pharma, when they were able to market opioids for pain relief. But they know more than they wanted to disclose. And because of that, there was some movement to help reduce the opioid use. And we started to see the statistics improve, but very slightly, because then they went on to heroin. In order to understand the who, what, and where of opioid use, we need to talk about how it began, and we just did, and who are the most vulnerable populations when we speak of opioid addiction, and what is being done to decrease that use. For those who are interested in a documentary on Netflix, it's called The Pharmacist, and I don't know if it's still playing. But the main character in the documentary, Dan Schneider, is a pharmacist living in Louisiana. When he loses his teenage son to murder in a drug deal for opioid, he then began paying attention to prescriptions that he was filling at his pharmacy where he worked, and learned that there was an abundance of painkillers being prescribed. He began his own investigation and thus began the exposure of the widespread opiate problem in Louisiana. We're going to see a quick video on the opioid epidemic.
More than 3,000 years ago, a flower began to appear in remedies in ancient Egyptian medical texts. Across the Mediterranean, the ancient Minoans likely found ways to use the same plant for its high. Both ancient civilizations were onto something. Opium, an extract of the poppy in question, can both induce pleasure and reduce pain. Though opium has remained in use ever since, it wasn't until the 19th century that one of its chemical compounds, morphine, was identified and isolated for medical use. Morphine, codeine, and other substances made directly from the poppy are called opiates. In the 20th century, drug companies created a slew of synthetic substances similar to these opiates, including heroin, hydrocodone, oxycodone, and fentanyl. Whether synthetic or derived from opium, these compounds are collectively known as opioids. Synthetic or natural, legal or illicit, opioid drugs are very effective painkillers, but they are also highly addictive. In the 1980s and 90s, pharmaceutical companies began to market opioid painkillers aggressively, actively downplaying their addictive potential to both the medical community and the public. The number of opioid painkillers prescriptions skyrocketed, and so did cases of opioid addiction, beginning a crisis that continues today. To understand why opioids are so addictive, it helps to trace how these drugs affect the human body, from the first dose through repeated use to what happens when long-term use stops. Each of these drugs has slightly different chemistry, but all act on the body's opioid system by binding to opioid receptors in the brain. The body's endorphins temper pain signals by binding to these receptors, and opioid drugs bind much more strongly for longer. So opioid drugs can manage much more severe pain than endorphins can. Opioid receptors also influence everything from mood to normal bodily functions. With these functions too, opioids' binding strength and durability mean their effects are more pronounced and widespread than those of the body's natural signaling molecules. When a drug binds to opioid receptors, it triggers the release of dopamine, which is linked to feelings of pleasure and may be responsible for the sense of euphoria that characterizes an opioid high. At the same time, opioids suppress the release of noradrenaline, which influences wakefulness, breathing, digestion, and blood pressure. A therapeutic dose decreases noradrenaline enough to cause side effects like constipation. At higher doses, opioids can decrease heart and breathing rates to dangerous levels, causing loss of consciousness and even death. Over time, the body starts to develop a tolerance for opioids. It may decrease its number of opioid receptors, or the receptors may become less responsive. To experience the same release of dopamine and resulting mood effects as before, people have to take larger and larger doses. A cycle that leads to physical dependence and addiction. As people take more opioids to compensate for tolerance, noradrenaline levels become lower and lower, to a point that could impact basic bodily functions. The body compensates by increasing its number of noradrenaline receptors so it can detect much smaller amounts of noradrenaline. This increased sensitivity to noradrenaline allows the body to continue functioning normally. In fact, it becomes dependent on opioids to maintain the new balance. When someone who is physically dependent on opioids stops taking them abruptly, that balance is disrupted. Noradrenaline levels can increase within a day of ceasing opioid use, but the body takes much longer to get rid of all the extra noradrenaline receptors it made. That means there's a period of time when the body is too sensitive to noradrenaline. This oversensitivity causes withdrawal symptoms, including muscle aches, stomach pains, fever, and vomiting. Though temporary, opioid withdrawal can be incredibly debilitating. In serious cases, someone in withdrawal can be violently ill for days or even weeks. People who are addicted to opioids aren't necessarily using the drugs to get high anymore, but rather to avoid being sick. Many risk losing wages or even jobs while in withdrawal, or may not have anyone to take care of them during withdrawal. If someone goes back to using opioids later, they can be at particularly high risk for overdose, because what would have been a standard dose while their tolerance was high can now be lethal. Since 1980, accidental deaths from opioid overdose have grown exponentially in the United States, and opioid addictions have also exploded around the world. While opioid painkiller prescriptions are becoming more closely regulated, cases of overdose and addiction are still increasing, especially among younger people. Many of the early cases of addiction were middle-aged people who became addicted to painkillers they had been prescribed, or received from friends and family members with prescriptions. Today, young people are often introduced to prescription opioid drugs in those ways, but move on to heroin or illicit synthetic opioids that are cheaper and easier to come by. Beyond tighter regulation of opioid painkillers, what can we do to reverse the growing rates of addiction and overdose? A drug called naloxone is currently our best defense against overdose. Naloxone binds to opioid receptors but doesn't activate them. It blocks other opioids from binding to the receptors and even knocks them off the receptors to reverse an overdose. Opioid addiction is rarely a standalone illness. Frequently, people with opioid dependence are also struggling with a mental health condition. There are both inpatient and outpatient programs that combine medication, health services, and psychotherapy. But many of these programs are very expensive, and the more affordable options can have long waiting lists. They also often require complete detoxification from opioids before beginning treatment. Both the withdrawal period and the common months-long stay in a facility can be impossible for people who risk losing jobs and housing in that time frame. Opioid maintenance programs aim to address some of these obstacles and eliminate opioid abuse using a combination of medication and behavior therapy. These programs avoid withdrawal symptoms with drugs that bind to opioid receptors but don't have the psychoactive effects of painkillers, heroin, and other commonly abused opioids. Methadone and buprenorphine are the primary opioid maintenance drugs available today, but doctors need a special waiver to prescribe them, even though no specific training or certification is required to prescribe opioid painkillers. Buprenorphine can be so scarce that there's even a growing black market for it. There's still a long way to go with batting opioid addiction, but there are great resources for making sense of the treatment options. If you or someone you know is struggling with opioid use in the United States, the Department of Health and Human Services operates a helpline, 800-662-4357.
Let's go into the crisis begins. And we already talked about some of this. In 95, Purdue Pharma receives approval for OxyContin. Then in 2007, they pay $634 million for lying about OxyContin. In 91 to 2011, prescriptions for opioids tripled. Even though they paid that money, for lying about it, they are still working hard to get their drugs out there. The head of Purdue Pharmaceuticals is just a ruthless man. In 2010, there was a release an abuse-resistant formula for They released an abuse-resistant formula for OxyContin. However, we know that it did not work.
Let's say that it would take you 10 minutes to solve this puzzle. How long would it take if you received constant electric shocks to your hands? Longer, right? Because the pain would distract you from the task. Well, maybe not. It depends on how you handle pain. Some people are distracted by pain. It takes them longer to complete a task, and they do it less well. Other people use tasks to distract themselves from pain, and those people actually do the task faster and better when they're in pain than when they're not. Some people can just send their mind a wandering to distract themselves from pain. How can different people be subjected to the exact same painful stimulus and yet experience the pain so differently? And why does this matter? First of all, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is something we experience, so it's best measured by what you say it is. Pain has an intensity. You can describe it on a scale from 0, no pain, to 10, the most pain imaginable. But pain also has a character, like sharp, dull, burning, or aching. What exactly creates these perceptions of pain? Well, when you get hurt, special tissue damage sensing nerve cells, called nociceptors, fire and send signals to the spinal cord and then up to the brain. Processing work gets done by cells called neurons and glia. This is your gray matter. And brain superhighways carry information as electrical impulses from one area to another. This is your white matter. The superhighway that carries pain information from the spinal cord to the brain is our sensing pathway that ends in the cortex, the part of the brain that decides what to do with the pain signal. Another system of interconnected brain cells called the salience network decides what to pay attention to. Since pain can have serious consequences, the pain signal immediately activates the salience network. Now you're paying attention. The brain also responds to the pain and has to cope with these pain signals. So motor pathways are activated to take your hand off a hot stove, for example. But modulation networks are also activated that deliver endorphins and enkephalins, chemicals released when you're in pain or during extreme exercise, creating the runner's high. These chemical systems help regulate and reduce pain. All these networks and pathways work together to create your pain experience, to prevent further tissue damage, and help you to cope with pain. This system is similar for everyone, but the sensitivity and efficacy of these brain circuits determines how much you feel and cope with pain. This is why some people have greater pain than others, and why some develop chronic pain that does not respond to treatment, while others respond well. Variability in pain sensitivities is not so different than all kinds of variability in responses to other stimuli, like how some people love roller coasters, but other people suffer from terrible motion sickness. Why does it matter that there is variability in our pain brain circuits? Well, there are many treatments for pain, targeting different systems. For mild pain, non-prescription medications can act on cells where the pain signals start. Other stronger pain medicines and anesthetics work by reducing the activity in pain sensing circuits, or boosting our coping system, or endorphins. Some people can cope with pain using methods that involve distraction, relaxation, meditation, yoga, or strategies that can be taught like cognitive behavioral therapy. For some people who suffer from severe chronic pain, that is, pain that doesn't go away months after their injury should have healed, none of the regular treatments work. Traditionally, medical science has been about testing treatments on large groups to determine what would help a majority of patients. But this has usually left out some who didn't benefit from the treatment or experienced side effects. Now, new treatments that directly stimulate or block certain pain-sensing, attention, or modulation networks are being developed, along with ways to tailor them to individual patients, using tools like magnetic resonance imaging to map brain pathways. Figuring out how your brain responds to pain is the key to finding the best treatment for you. That's true personalized medicine.
Once you understand pain, you can appreciate how things like opioid use got out of hand. And I remember as a nurse back in the 1990s, the shift from pain management took a seat when it came to patient satisfaction. We were taught that no one ever should feel pain, and there was now a medication that helped control that pain. Like I said, I was a labor and delivery nurse at the time, and the management of post-delivery pain, such as incisional pain, whether delivery was vaginal or cesarean section, was, we used like Darvocet and Percocet, which were kind of low dose type opioids. And the patient was sent home with prescriptions for both that could be renewed. The patient did not suffer any pain, but little did we know at the time that this was being led by Big Pharma, and things quickly escalated. So the patients were feeling better, but we didn't know how many people were getting addicted to this because there was no time effect on or restrictions on how many refills someone could get on their medications. So let's address the type of pain. So the first type of pain that I want to talk about is something called somatic pain. And somatic pain is pain that you feel in the skin, the bone, the joint, muscle, or your connective tissue. And it presents with throbbing and well-localized sensation of pain. And then we have visceral pain. And visceral pain is coming from an internal organ. You may have a feeling of pain from another location other than location of the organ. For example, if I have appendicitis, I'm going to feel it right around my belly button. But my appendix is not by the belly button, it's off to the side. So any what we call visceral pain, you can have a localized pain, or you can have what we call a referred pain. If I have a gallbladder, I'm going to feel that pain in the back, and I might even feel it in my chest. That's what we call visceral pain. The neuropathic pain is really caused by nerve damage, and you might feel burning, tingling, or shock like or shooting pain. So I just had a total knee replacement, and the first pain I experienced was somatic. So it was joint, muscle, or connective tissue. And then the next pain I felt shortly or intermittently in between the somatic pain was the nerve damage pain. And that's where on the skin, they cut my skin, and then, they have to cut into the muscle tissue and get down to the bone, and it's going to affect those underlying nerves. So I can describe that burning and tingling type pain that I felt. And if anyone out there has had that similar surgery, you know what that feeling is like. And some of that pain, neuropathic pain, can really last for up to about 6 months on some instances. Our next one is acute pain. And that typically occurs from an injury and lasts about 3 to 6 months. It usually resolves once the tissue is healed, and it can be described as throbbing, sharp, burning. Persistent and chronic pain are really the same. The thought is that chronic pain needs to be fixed. Chronic pain is more common in older adults. Pain can last for 3 months or longer. I know in my post-op information I got for my knee replacement, it told me that I may have pain for up to 3 months after my surgery. We know that acute pain may not be associated with any recognizable diseases or processes. So example, I just might have general arthritis, and I might have acute one-day pain from that, and then I'll have that chronic pain, and that's the one that lasts a little bit longer. 1 in 5 older adults are taking analgesic medications regularly, while 63% have taken prescription pain meds for greater than 6 months. Older adults have many reasons for persistent pain. They have degenerative joint disease like osteoarthritis or other types of arthritis, or it might be pain related to chronic back pain, myofascial pain syndromes, neuropathic or nerve pain. Post-stroke syndrome can cause pain. We have headaches related to, blood flow, or it might just be a neck issue. It might be toothaches, oral pathology from poor dentation. Osteoporosis with a fracture will cause pain. But we know that the one thing is that there's very little research done that focus primarily on pain in the elderly. We also know that multiple treatment options are available. We do know that when dispensed in an appropriate fashion, opioids can be safe. I had a 10-day prescription of opioid that was dispensed to me after my surgery, and I was encouraged to try Advil in between that. They expected in the outpatient discharge plans for me that I should not be using any opioids after 2 weeks, and if I felt I needed more coverage, that I needed to call them. And so it's a process now. You can't just say, I need more pain medicine. In general, we do know that pain is undertreated in older adults, and undertreated pain is associated with poor sleep, depression, anxiety, decreased function. So, there's a lot of things that we can look at to help with acute and chronic pain. So here are some of the common opioids that are used for pain management. Some of these are involved in when the opioid crisis began. They were used believing that they did not have addictive properties, and that the side effects really outweighed the risk of using these. Once regulation began to tighten up, people who were initially prescribed now moved to, like I said, the illicit options to obtain their opioids, either buying it secondhand from a drug dealer, or going to heroin, or going to the synthetics. If older adults had a history of drug misuse, they may be considered at high risk for drug use after they have a problem with pain. But for the most part, the healthcare industry didn't think that older adults could intentionally misuse medications. And we do know that does happen now. We talk about what makes older adults so vulnerable, but first let's talk about opioids and how, if used correctly, can benefit a person experiencing pain, and if misused, the risks that may be involved in that practice. So there's a connection between substance abuse and mental health association. Methadone is a safe and effective medication approved by the FDA, to treat opioid use disorder as a medication-assisted treatment. It's also used for pain management. It's a long-lasting opioid antagonist, and what it does is it reduces the opioid cravings and withdrawal and blunts or blocks the effects of the opioid. It is safe and effective when taken as prescribed. Methadone achieve and sustain recovery. When taken daily, it's available in liquid, powder, and dissect forms. One component of the multifaceted treatment plan, which includes counseling and behavioral health therapies to provide a patient with a whole person approach. So if we look at methadone, that has two purposes. For someone who was a drug user previously and has been clean and is starting to have chronic or post-surgical pain, and they let their provider know that this has been a problem, then they will choose methadone as a choice of treatment for their pain. But methadone is also a medication that can be used to wean someone off of opioid use. Success rate, not real good. But it is, when it's used alone, I should say. It really needs to, if you're using methadone for someone to get them into recovery, you really need to have an interdisciplinary approach. And for some people, that means being admitted to a community where, facility where it can be treated, and then they'll use methadone. If we look at the benefits and risks of opioid use, we know that it can work with pain management. It increases functionality. It'll get you up and moving. I know after, again, I'm sorry that I'm relating to this leg, but it's a good teacher for you right now, because, and if anybody was out there who's had a hip or a knee or a shoulder done, you know the type of post-op pain you may have. And when you're in pain, it's difficult to move around. And when you don't move around, you're going to have breathing complications, constipation, nausea, and things like that. So the benefit is, if you use the opioid and you use it wisely and as prescribed, it will increase your mobility, which improves your quality of life. It'll help you maintain some independence because you get that reduction of pain. However, we know that there are risks to that: constipation, nausea, breathing complications, because it may make you somnolent, fatigued, and you might be sleeping more than you should be. So you need to be up and moving, and that helps aerate your lungs and get fresh air down and oxygen down in those lungs. You see some confusion and disorientation. We know that there's drug interactions with opioids and other medications, and if it's not used correctly, it can lead to death. So let's look at the risk factors of opioid use in older adults. So the vulnerable group that we're speaking of today, as I said, would be our older adults. But what makes them vulnerable? Out of any age group, older adults have the highest rate of chronic pain. And to keep them functional, mobile, and active, we need to meet their pain needs. Also, older adults tend to have higher rate of falls, which results in injury, and most frequently broken hips, broken shoulders, wrists, and ankles. They also have more complex health problems. They may often have more than one comorbidity: congestive heart failure, diabetes, COPD, autoimmune diseases, liver and kidney issues. Those will all potentiate the risk of using opioids. Older adults have a higher level of anxiety and depression, and that may be an underlying issue that affected prior, but sometimes that will resurface or redevelop in older years. And this can be a result of family partner losses. They may experience loss of home, independence, and financial issues. Many older adults are on more than 4 medications. In fact, the typical adult is typically taking 9 medications daily, and this can become complicated and difficult to manage, as well increase the risk for accidental misuse for medications such as opioids. Having a history of addiction, like I said, puts one at risk for relapse. Remember, addiction is a chronic brainwave disease that can occur, have you with recurrent relapses if that happens in older adulthood. This not only includes drugs, but also alcohol. And as we age, our bodies change also. The kidneys and liver are more challenged when it comes to clearing medications through your body. Because of anxiety and depression and dementia, there may be change in someone's executive functions, which we will see causes poor decision making. So those are some of the issues with older adults. So again, we look at some of the vulnerable age populations. When looking at the opioid crisis, we can target different groups that are more vulnerable than others. The older adult is the age population that we consider vulnerable, and let's look at some of those reasons. So again, there's systematic changes, age-related changes that affect how we process medication and alcohol. Our lean body fat decreases. However, our fat does increase, and that stores a lot of stuff for us. Total body water decreases. We have kidney, renal changes, decreased liver function, and most drugs are metabolized by the liver. We also see changes in the brain in our neurotransmitter. We also look at lack of education and knowledge. 60% of the medication is not taken as prescribed or directed. 1 in 4 older adults skip doses of medications or does not fill the medications due to cost. Multiple prescriptions and long-term prescriptions also may interfere and interact with the use of opioids. And we never really consider the use of over-the-counter medications, but really, most importantly, too, herbs, dietary supplements, along with those prescribed medications. So as you're giving your history to your caregiver, your professional caregiver, if you're on, and they usually will ask now, are you on any herbs or supplements? Because we know that many of the herbs and supplements may have an interaction with opioids. And like I said, prior substance abuse will also affect, so keep in mind that addiction is a primary, chronic, and relapsing brain disease. And again, mental health can play a large role in the use of opioids. So those are some of the issues that we look at. And we're looking at this change in fat and muscle ratio. Also, there's visual changes. So we're not reading the bottles properly, changes in coordination and balance that we typically have as we age, and opioid use or drug interactions can potentiate that increased risk for falling because of those changes in coordination and balance. That slowing metabolism, if I'm taking a medication and then I'm taking an opioid, I'm not sure that that other medication has cleared my body in time. And now I've got 2 things working at the same time. And we look at the reduced water in the cells and the tissue of the body. That also has can also affect any medications. And then polypharmaceuticals, using more than just a couple medications, and so that's why it's important for older adults to make sure that they're getting their medications evaluated at least every 6 months. If we look at the older population, you think of nice grandma and grandpa, and the thought of either one of them having a substance abuse problem, that seems inconceivable and it wouldn't exist. But as a matter of fact, as the baby boomers grow out, we are seeing an increase in this age population with higher rates of substance abuse. As a matter of fact, in current studies of the surgency of marijuana shops, one of the most frequent customers in many of those shops are those in that baby boomer age group. Whether they're seeking pleasure or they're seeking pain relief, many of those who walk through those doors of a dispensary have already used in their younger years and don't have a problem returning to using. These are not just hippies of the 60s, but they come from all walks of life. Teachers, lawyers, white and blue collar workers who all belong to the same group. As you can see, women over 60 are more likely to use opioids than their male peers. As I can't seem to find a resource to explain this, I'm assuming that there is more loss among women since they live longer than men. And because they live longer than men, they also may acquire more comorbidities, something like arthritis or another autoimmune disease that would cause some kind of bone or connective tissue disease. Maybe it's more fractures due to the increased risk of osteoporosis, but we don't know. Lastly, studies show that if you have a substance abuse problem, like I said, in your younger years, you're more at risk as an older adult to use again. So if we look at pain management in older adults, it's essential for our providers to assess the pain correctly to assure the patient is pain-free and the medication that they're using is appropriate for the type of pain that they may be experiencing. So how much pain or how severe is the pain for you? One of the things that you can use is the pain scale, and it can be used for nonverbal, different types. We'll see different types of scales for people who have changes in their cognition or speak another language. They may just be more picture type. But a lot of times the one that you may be asked most frequently is on a scale from 1 to 10, 10 being the worst pain and 0 being no pain, where are you at right now? And if you're going towards 5, we're getting a little concerned about you, because the problem with pain management is if you let it go too long, it's really hard to get it back. So we like to start treating patients for their minor pain around 4 to 5 and see if we can kind of nip it in the bud. But, that's a real quick way to assess. But there's other ways to look at that too. And this is one more of a picture, and it's called the Universal Pain Assessment Chart. And you can see that 4 to 5, now we're getting into moderate pain. This is mild pain. This I can still work and not think about my pain too often. Now this interference of that thought of pain is starting to impact our quality of life and how we're living that day. And then, of course, severe pain and worst pain possible. Even with my, and pain is comparative, and it's going to be different for every person. I had heard horrible stories about pain management during my knee surgery, and yet my pain never got above 6. Now, is it because of the way the surgeon did things? Is it that I have a good pain tolerance? Every brain and every receptor in your brain that receives that pain message is going to be different for everyone, but we have to treat them on what they're feeling. This is just another example of, of pain management. This would be more for someone who is nonverbal, that can't talk. And so we look at the facial grimaces, we look at their movements or the rigidity in their body. We look at something called guarding, and that's when you're splinting the area that hurts. You have a toothache, you put your hand over your jaw. You have, you hurt your elbow, you put your hand over your elbow. If your shoulder hurts, you put your hand on your shoulder and rub it. That's called guarding. It's a natural response to pain. And people, even when they're nonverbal, will still do that. So that's what we're looking at for people who are nonverbal. So I think when we're assessing pain in older adults, we need to look at the history of pain. It's very important. It's difficult to assess those with dementia, but looking at that last pain management tool, I think it's important that we look at that and we look at the body language that person is experiencing. So let's go back to the problem that we had, and that the opioid issue was getting larger and larger. So in 2015, the Health and Human Service Secretary Sylvia Burnell announced and initiated in response to the healthcare opioid epidemic. It included suggesting opioid prescription practices, and it expanded the use of Narcan or naloxone, which is commonly called Narcan. Its expanded use of medication-assisted treatment, adjusting therapies such as physical therapy and things like that. It said instead of giving them pain medication, let's work on other ways to manage their pain instead of giving them opioids all the time. It might be physical therapy. It might be heat packs. It might be ice. It might be, now we're looking at red light therapy for certain pain issues, chronic pain issues. So there's a lot of other things that we can use besides medications. We know sometimes medications are what's needed to get that pain level down, but as we get that pain level down, then we can work on treating it maybe outside the opioid arena. In 2016, in March, the CDC guidelines for prescribing opioids for chronic pain. What it says is that we have to explain the benefits and risk associated with prescription opioids. We have to provide evidence-based guidelines for clinicians and patients in shared decision-making about the use of opioids for chronic pain management. So oftentimes you'll hear someone say, I don't want to take opioids because I don't want to get addicted. The first thing that we ask them as practitioners is, do you have a history of addiction? Have you have a history of alcohol addiction or drug addiction? If they do, then maybe we need to talk about different options that are out there for them, for their pain. However, if they're not, what we need to do is talk to them about the measures that have been taken to reduce the overuse of opioids, that they'll only be given a certain amount. And then we start to introduce things like Tylenol or Advil or Aleve or something else, and then use ice in that area, use heat in that area, turn several times a day. Let's get you involved with physical therapy. And you will only have those opioids for a certain amount. Talking about those risks and benefits, one of the big risks with opioid use, and it doesn't have to be prolonged, it can be short-term, is constipation. And being someone who only took it for 3 or 4 days, I can tell you that that's all it takes. And so they usually will prescribe something to work against that, something like a stool softener that will work against the use of the opioids, because it doesn't take very long for that to kind of start to build up in your system and cause constipation that can be pretty uncomfortable. But these are all the things that the providers should be talking to their patients about, or at least giving them handouts. The nurse that's discharging them, maybe from the hospital, needs to have those conversations. So the prescribing guidelines does state long-term opioid use has uncertain pain management benefits, but known serious risks. So again, what we're saying is, for short-term, it's good. For long-term, it can really, end up a different way. And then in October of 2017, the HHS declares a nationwide public health emergency that exists due to the opioid crisis. So we can see that we've gotten pretty far in what we need to do and talk about. So what's the CDC guidelines for prescribing opioids for chronic pain? When starting opioid therapy, prescribe immediate release opioids instead of the extended relief. What was happening was, when you were giving people extended release, they were overlapping. So now they were double drugging themselves. When prescribed, use the lowest effective dose possible. Again, discuss those risks and benefits of opioid therapy with patient prior to the treatment. Revisit possible risks versus benefits at least every 3 months. And typically, for most people who are being treated for acute and post-op pain, you probably won't need those opioids for 3 months. But if you do, for other conditions, that doctor needs to discuss those risks and benefits every 3 months. It's important that the CDC says that we have to establish treatment goals with that person, including a plan for discontinuation of the opioid therapy if risks outweigh the benefits. And then we also need to review the person's past history of controlled substance abuse. So again, that's a question that's asked up front. Use drug testing to identify other prescribed medications as well as illicit or undisclosed drugs if necessary. And then offer and make arrangements for evidence-based treatment options for those with who have an opioid abuse disorder. So I don't know if you can see this very well, but this is the opioid drug potency compared with oral morphine. So if we look at meperidine, which is at the top, that's Demerol. And we look down at the bottom and we see hydromorphine, which is an opioid. And then we look down at fentanyl. That's the most has the most drug potency out of all of them. So you can kind of see down the list where hydrocodone is, oxycodone, methadone, oxymorphone, and then we go all the way down to where fentanyl is. Fentanyl is used in healthcare, but and most commonly we see it in fentanyl patches for people who are experiencing a lot of back pain or cancer type pain. But again, it's a controlled substance. When you see it on the street, it is synthetically made, and that's what causes it to be deadly, but also because you don't know the amount that you're getting. When you're taking a fentanyl patch or you're getting fentanyl IV, it is titrated and dosed the right way, and it's given under controlled conditions. So that is the difference on that. So if we look at prevention, I think limiting the initial dose and duration and avoiding dose increases are the CDC guidelines for opioids. And then minimizing the use of other sedating medication is appropriate. Remember that sedating medications in general are not always appropriate for older adults for several reasons anyways. So if you're using a sedating medication and an opioid, someone's going to be very snowed, and that really puts them at risk for overdose, for falls, for poor quality of life. There's a lot of problems when you're mixing those. If a person, again, has a history of prolonged opioid use, then recovery are at a greater risk of overdose. This has to do with the tolerance and the use of the higher dose to achieve pain relief. Now, Narcan is an effective drug to reverse overdoses from both prescription opioids and heroin and fentanyl. As an opioid antagonist, Narcan binds to opioid receptors and can reverse the effects of other opioids. It can quickly restore normal respiration to a person whose breathing has slowed or stopped as the result of heroin or prescription opioid. Several overdose education and Narcan distribution programs have been developed to issue Narcan and provide instructions on its use to opioid users, their families, and loved ones. You can get Narcan in quite a few places. I've seen them at Walgreens. I've seen them at CVS. People can easily buy Narcan over the counter, especially, and many people do if they know that their family has a history of drug use. My son's a firefighter, and they called someone, they called someone in because at the store that they had called him, there was a guy who was out cold in the card aisle, and so my son used Narcan because he was not breathing and he didn't have a pulse, and he used Narcan, and almost instantly within a minute he's back awake What happens, though, typically with Narcan, with a situation like that, is they wake up very combative because now you've ruined their high. And you have to be very careful when you give Narcan. You have to kind of move back a little bit because they may wake up and knock you one. But it is a very effective medication. So World Health Organization organized a criteria for pain management, and here's what it looked like. And this was back in 1990 when we figured out things were really going crazy. We had mild pain, moderate pain, and severe pain. And you can see for mild pain that they don't recommend opioids at all. Acetaminophen, nonsteroidal anti-inflammatories, COX-2 inhibitors, and then adjunctive therapies like heat or ice, rest, massage, physical therapy, thing like that. Then we have moderate pain, and you can use a weaker opioid like oxycodone or hydrocodone or codeine. And that is, you use, again, those adjunctive therapies. And then for severe pain, we're talking about hydromorphone, fentanyl, and non-opioid, strong opioids. So again, with the adjunctive therapy. So there's, they have a criteria, and practitioners need to look at this as they're medicating people for their pain issues. So how can we help as people, and know that this opioid crisis is cross-generational? We look at the younger people and how do they get addicted to opioid? Is it peer pressure? Yes, sometimes it is peer pressure. They've always said that, marijuana is the gateway to other drugs. We know now that, so they say that marijuana is non-addicting. However, they do say that there are brain changes in people who use it younger, like 13, 14, 15, people who are up until their late teens, that there's definite changes in the brain with people who are using marijuana, or what they call on the street weed. But we also know that that we have seen people get addicted because maybe our basketball players or football players, someone falls during a game or gets injured and fractures a bone. And one of the ways that they can fix that acute pain is to use an opioid. If they don't use a mild opioid and they jump to the next level, they have to be very careful and monitor that person, because we all have opioid receptors in our brain, and some are more active than others. And this can really put that younger person on the path to opioid use. So, and is it easy to get on the street? It's very easy. It's easy if you have money. So what happens to a lot of our drug addicts is they start doing things like stealing and selling things, and maybe, prostituting. There's a lot of ways that younger people get their street drugs. And sometimes it was started very innocently. Sometimes it has started, like I said, because of peer pressure. They may have some mental illnesses that they're dealing with, and this kind of numbs that. So it's not just older adults. I specifically talked about older adults today because we know that there are issues across the continuum, from the younger people in their early teens, later teens, and then there are some people that are very active in their 40s and their 50s, and then they move on to being older adults. So we know that it crosses generations. But what can we do to help? We need to be supportive and non-judgmental. We need to ask the right questions when we're assessing someone. How do they normally handle their pain? When were they last assessed for their pain? Do they take an over-the-counter medication? If your provider is not asking you these questions, you tell them that that this is how you normally handle your pain, and that you really haven't been assessed for your pain in a while, or it was just last week. And then the over-the-counter pain medications that you take, along with the other medications that you take, as well as herbal and vitamins. Is there a history of chronic disease, current surgery, or drug or alcohol abuse? And again, we can't be biased when we're working with these people, because otherwise we will not be giving them the care that we need. So you need to make sure that if you're in a situation where you are in a healthcare facility, that you're connecting with those healthcare providers in a supportive way. And then describing your pain to them is really important. Is it chronic? Is it acute? Where's the location of it? What does it feel like to you? Does it feel like a tingling, a burning, a stabbing pain? And then, tell them where you are on that pain scale. We need to be careful and not borrow other people's pain medications, because we don't know what they may have in their bottle and how it may affect us if we've never taken it before. Talk to your doctor about different treatment options, different medications. Make sure that you get educated about the medications that you're going to be taking, and also what are other things that you can do that can help with relieving some of that pain. Again, ice, heat, massage, physical therapy. Those are all adjunctive therapies. There's a lot to be said about aromatherapy too. There's certain essential oils, and I don't know the names of them offhand, but you can go onto an essential oil website and find out what essential oil helps reduce pain. That's such an easy way, is just put a little essential oil on your wrist, and having that smell can kind of calm those pain receptors. So there's a lot of different ways that we can work on pain relief. But if you have the opportunity, again, to look up Purdue Pharmaceutical and get the history of it, I don't know if any of those programs are still on TV or not. But again, you can see how greedy the pharmaceutical company was and how far they went to pursue people to use their medications. So that's it for today. I want to thank you all for staying with me.